Dear Dean of the Medical Faculty and dear Adonis, dear colleagues and dear guests, χρόνια πολλά, καλή χρονιά, Happy New Year, and thank you very much all coming this night to listen about my academic research. Actually, I'm going to talk about the uterus environment. Uterus is an organ that I'm mostly interested, I would say, from all perspectives. Training on operating on uterus or researching on the uterus, and of course, our life starts from the uterus, of course. So not only starts, but also good health starts from in utero life. And the uterus is a very complex organ actually, because it's the organ that matures the latest from all organs. Because in utero life, the uterus has a very small, magnitude. And you can see here, you can see yes. So you can see the newborn uterus here, and then by 4 years of age, and you see how the macroscopically changes in ratios between the corpus uteri, the body of the uterus, and the cervix. And this maturity starts only by 28 to 32 weeks of gestational age and finalizes around the age of 16, 17 years of age. So the organ is exposed continuously to epigenetic factors, to environmental, pollution, etc. factors that can change its appearance macroscopically and microscopically, of course, and its functional its function as well. So indeed, the uterus is a very complex organ because not only macroscopically or functionally, but also the network of the uterus is very, very complex and interesting. And I would say that is the organ that has been interesting for most of the researchers. And the reason is because the non-gravid uterus, the non-pregnant uterus, is very difficult to deal with it, especially from the ethical point of view. Although a lot is done for the pregnant uterus, very few things have been done for the uterus that is not gravid, the non-pregnant uterus. And just in 22, after 5 years of research in the literature, etc., we came out with this paper published in the Advances in Clinical and Experimental Medicine regarding the new insights into the neural network of the non-gravid uterus. And you can see, apart from the regular nerve networking that you have from the spine, of course, you have a very peculiar system, including neural network, a local one, the telocytes and prostaglandins, and the Cajal cells. Cajal cells, these are cells that they operating locally, like in the bowel, for example. So the bowel, in order to have a propagating wave and push the mass from one point to the other, these Cajal cells operating in a sense that they create propagating waves, and in that way we have a peristalsis, not only contraction but also peristalsis. And this happens also probably in the uterus. So apart from the sympathetic, parasympathetic systems that we have coming from the spine, we have the local networking of the uterus creating these contractions. Also, we divide the uterus in two structures. We have the archimitra. The archimitra composes only this endometrium and the subendometrial area. So the muscular part of the uterus comes only later in life, after the Homo sapiens. The Homo erectus, it didn't have this muscular part because it used to go on four, like the monkeys today, the anthropoids. They don't have a muscular part of the uterus, but they have only the archimetra that contains only the endometrium and the subendometrium contracting area. So in the non-gravid uterus, what we are experiencing only the contractions that they are created by this subendometrial area, so-called junctional endometrium. This special area, this is the area that produces the contractions of the non-gravid uterus. While during menses and during labor and delivery, we have the muscular part, the neometra, that functions mainly to deliver the baby or to expel the menstrual blood from the endometrial cavity. So what we have in clinical practice, when you compare the heart, for example, with the uterus, you have the heart, and usually you know that we do the ECG, the electrocardiogram. So when you have patients that we want to control their heart, we first make electrocardiogram, and then we do the echo, the ultrasound. In case of gynecological reasons, we go straight forward to the ultrasound. Have you ever heard that there is any machine or a way to check the physiology of the uterus? Until now, no. However, we created the ElectroUteroGram. So the idea is to resemble exactly the same components, the same ways that you explore for the heart problems. So doing the ECG, in the same way, we created the ElectroUteroGram, and you can see that the ElectroUteroGram, you have these propagating waves, these peristalsis of the uterus you can see in this ultrasound detected peristalsis with the ElectroUteroGram, which is a device that we explore in the last 5 years. So yes, the contractility is very important pathway of the uterine function, and contractions are associated with the fertilization, the implantation, the early pregnancy preservation, the menstrual blood clearance, and endometrial rejuvenation, of course. And since 2015, we have a project, we call it the DIMEC project, which stands for Direct In Vitro In Vivo Monitoring of the Endometrial Cavity. And our we focus especially on the activity of this junctional zone endometrium. So we developed a recording device, an electrode that is passing within the endometrium, the same way that you put an IUD, the intrauterine device, or you do a pap test. Very similar way, we pass this electrode within the endometrial cavity, and then you take these recordings by a monitor, and of course it is a safe, painless, and harmless innovation that you can detect this contractility of the uterus. And you can see in these diagrams, actually, this is what we call a sheath, a very small catheter that we use for embryo transfer. In a very similar way, instead to put the embryo catheter, we put this electrode, which is quite thin, and we can detect, you see in this monitor, these waves. And these waves are very similar, of course, to any other waves like you get from any muscle when you do an electromyograph. So this is the electrode. Is only 1/4 of a millimeter thin, and we have about 7 electrodes, as you can see here, that they measure every 1 centimeter within the endometrial cavity the contractility activity. And of course, this electrode can be seen also by an ultrasound, either abdominal or trans-vaginal, and you can see even the electrodes one after the other along the pathway from the fundus to the cervical end of the uterus. To remind you that in the cervix, there is no so much activity because there is no muscle actually. Again, we found very interesting results during our research. So far, we have 280 women that participated with multiple EUG recordings, with normal uteri and also various pathologies. We had 0 complications or complaints. So ElectroUteroGram, the EUG, an innovative instrument, can really evaluate the uterine electrophysiology right away from the core source of these contractions. Because until now, we could see these contractions by MRI or ultrasound. But both machines are quite expensive and very difficult to operate. You need a real ultrasonographer with a lot of experience, and the fact that this is not so, let's say, convenient is because still measuring the contractility of the uterus is still experimental. So our first results show that when you have estrogens, you have more contractions of the uterus, and also when you have progesterone, the second half of the menstrual cycle, you have less contractions. The frequency is low, but what we show something very interesting, the contractions are stronger. So when the contractions are more frequent, are less strong, but when the contractions are less in frequency, they are much stronger. And you see this area is the most interesting area here, about the A21, 22, where is the area, is the time that you have the implantation window, what they call. So during this implantation window, we need less contractions. But still, even these 1 or 2 contractions per 10 minutes, that is, they happen, then they are quite strong, because in that way, the implantation takes place. Another interesting result is this chart here that you show the normal uterine intensity. So you can see here, just here, the normal uteri as compared to the pathological ones. And here is adenomyosis or fibroids. And you see these significant differences in the early proliferatory phase, as well as in the early luteal phase and late luteal phase, when you compare the normal uterine function with the abnormal ones, those with adenomyosis, those with fibroids and infertility. So indeed, the EUG can help us to identify the uteri with problems. So the derived EUG measurements were able to monitor statistically significant changes of the junctional zone endometrium, the electrical activity. You remember where this junctional zone is. I told you it is between the endometrium and the subendometrial area across the menstrual cycle arising from the uterine contractions. And EUG seems to provide numeric parameters useful for interpretation of uterine function in a similar way the ECG works for the heart. And indeed, there are several papers mentioning that the uterine peristalsis before embryo transfer affects the chance of clinical pregnancy, but contractility, as I mentioned before, is still not used to improve fertility treatments. And the reason is mainly that we didn't have so far the correct device to be used. And another colleague from Netherlands published already in 2017 that we think an accurate, objective, and user-friendly measurement tool is needed before uterine contractility measurement can be incorporated into the standard workup for fertility patients. And of course, indeed, we believe that EUG is the one that can play the role of this exploration of the uterine physiology. And EUG is expected to provide further information and improve treatments for the fibroids endometritis, endometriosis, adenomyosis, and not only that, but also for early endometrial cancer detection. So we published already 2 papers. Our last paper published just 2 days ago, where we describe our experience with AUG and the first patients. And of course, both papers focus that EUG can accurately measure uterine electrical activity in a simple, standardized, safe, and pain-free approach, leading to an objective evaluation of the uterine peristalsis. In May 22, we had an ESHRE campus. ESHRE is the European Society of Human Reproduction and Embryology, and we had a hybrid meeting from all over Europe, participants, and it was very interesting to see that all were very excited about this new device, and they mentioned that Tanos made history yesterday in Cyprus, presenting for the first time the data on ElectroUteroGram, the direct recording of uterine peristalsis in a non-gravid uterus. So the ESHRE, the European Society of Human Reproduction and Embryology faculty, as well as members, were excited about this, and they were all interested to try this new device. We have international advisors, and we have prepared a clinical trial. Among them is from Johns Hopkins, Professor Andreu, Jeffrey Arnold from MIT, Professor Watts from Leuven, and Mark Marthams from Reading Hospital in the States as well. This is my team that I thank very much for the construction, and here is my co-principal investigator, Professor Giulio Georgiou from the Electrical and Computer Department in the University of Cyprus. So we're moving forward now to another area of interest, what we call the minimal invasive surgery. Today, you know that the office procedures are probably 95% from all our activities. These minimal invasive surgeries are performed by sedation, few hours hospitalization, and among them are hysteroscopy, trans-vaginal laparoscopy, hysteroscopy, and nodes, the natural orifice trans-endoscopic surgery, and laparoscopy. And you can see in these videos, for example, that we are using very small, tiny telescopes, using 3 monitors at the same time, together with ultrasound, and we perform several times the fusion of the images between MRIs, transvaginal ultrasound, abdominal ultrasound, and of course, the endoscopic surgery. So in a very detailed way, surgery has changed a lot. Today, we are using endoscopic surgery, and this is particularly useful because it provides magnification, clarity, precision, and of course, improving surgery results with less pain and hospitalization. Even you can see this video trying to remove a foreign body from a vagina of a child. But until today, the majority of the surgeons are using these images only for facilitating surgery. Image data can provide a huge and a useful information about tissue, of course. Macroscopic appearance and microscopic characteristics can provide much more than naked eye can diagnose, and definitely these data can be used. You see a smart surgeon here is trying to remove this big screw from the vagina, but it's very difficult because we don't have instruments. You see, it's not a daily practice to remove screws from the vaginas. So you have to be innovative. We pass this thread, and with this thread, we remove the screw out of the body. Of course, hysteroscopy, it's an amazing instrument because with a very small telescope, you can get into the uterus. The uterus has only 3 cubic centimeter volume. So it's very tiny volume. And we can use these devices in order to be able to identify lesions and, of course, to make diagnosis and treatment at the same time. However, still we have colleagues that are using the traditional dilatation and curettage. And this is unacceptable at this moment, because the recurrence rate of the pathology is more than 33% when you are using the traditional DNC compared to hysteroscopic approach. And of course, the combination with the ultrasound makes things even more fascinating, because as you can see in these videos, we are using tiny scissors, microscopic ways like these 5 French scissors is only 2 millimeter, that you can enter in the closed tube, and you can open the tube and perform adhesiolysis, and in that way the patient regains the correct, passage, the free passage in the tube. In another case, you can see here the innovative instruments, how they eat actually the lesion, as you can see here, with rotational movements, and also traditional scissors. This is one of my cases that it was very difficult, because it was a lady of 70 years old. The cervix was really very stenotic, very difficult to operate here. The only way you could solve the problem was to remove the uterus. She could not remove the uterus because she had other problems. So I operated her with small scissors, 5 French instruments, and you see this huge polyp, about 5 centimeters, that we cut it on this way, and it was removed from her body, and of course it was not cancerous. As I mentioned before, we use so far only the data, the images, to facilitate surgery. But these images can provide you an enormous data for evaluating the tissue. So to perform optical biopsies, what we call, and this got to be published a long time ago, about 40 women with 52 hysteroscopic images, where the sensitivity of this computer-aided diagnosis of tissue using imaging analysis reached 81% sensitivity and 78% specificity, comparing healthy endometrium to hyperplastic endometrium, which is a precancerous condition of the uterine cavity. So it was quite fascinating to continue this research. And recently, just in 21, we published another review study on the current status of the applications of CAETIA, the computer-assisted tissue image analysis, showing that we are still the pioneers on this aspect. We receive everyday calls and invitations to give our data and write more papers about this matter. I believe that very soon we'll have another big grant for these studies. Of course, imaging is not enough. You need to include also biomolecular and genetic prognostic factors. We published also about molecular factors that they are involved in the decision-making or in early stage endometrial cancer. And in this systematic review, as you can see here, we try to combine the molecular markers in endometrial carcinoma with a computer-aided tissue image analysis, the optical biopsies, and we mentioned that we can improve patient safety and the surgical results. Of course, we have this data, but our systems cannot provide the necessary archiving system or application of all these data in combination with the treatment of the patient. So we developed recently the history report. It's another project that we try to, in a holistic way, in a systematic way, to bring all the examinations and findings reported as necessary. So we look forward to an organized, structured, and detailed reporting hysteroscopy and intraoperative use of ultrasound, capturing images and videos. And we take this example of the obstetrical ultrasound, where you can improve the efficiency of diagnostic hysteroscopy and will enable the standardization and efficiency of diagnostic hysteroscopy and will allow the performance of studies, including the application of artificial intelligence algorithms. Already we have one thesis student, two master students, one PhD student, and one postdoc that they deal so far with this project. The natural orifice trans-endoscopic surgery, it's another interesting part of my research. So we are using the what we call trans-vaginal hydrolaparoscopy. You see these very small, tiny instruments here that they are only 2.3 millimeters in diameter. You can introduce them through the posterior fornix of the vagina, just below the cervical os, where this tiny area is only 5 millimeter thickness. So in a very easy way, I would say, you can introduce this needle, we put normal saline, and then we can introduce the scope, and with this scope we can have these marvelous images. So you are watching now, for example, the fimbria of a tube. And of course, you can see how we treat the distal stenosis of a tube. You can see here the stenosis of the, can you see probably if we reduce the light will be much better. And you can see how we can inject a blue, methylene blue dye, and it can be, you see it's coming out. After we manage to open the tube at the internal area, or in the internal cavity of the endometrium, also you see the stenosis of the tube that we manage here, and finally we have this injection of the fluid followed up by ultrasound. And this patient stayed pregnant only after 2 months of this exploration. Also, early stage endometriosis, as you can see in these videos, can explore the ovary at the very early stage of endometriosis development, clean up the area with this bipolar needle, again, fine French instruments, it's only 2 millimeter, these instruments. So you apply microsurgery, and again, we have excellent results after these surgeries. And you can see the detailed analysis that you can gain from these endoscopic surgeries compared to what naked eye can diagnose. This is another case with an endometrioma. So when these endometriotic lesions are left on the ovarian tissue, they form these endometrioma cysts. So now you see in this video how an endometrioma cyst can be opened, and then by bipolar probe can be ablated, can be coagulated and treated. While using a bipolar needle, we perform what we call ovarian drilling in PCOD patients, especially those patients that they don't have regular menstruation. Again, in these pictures, you can see a very detailed analysis how endometriosis lesions can be developed, and slowly they can penetrate further into the organ. And what happened in these cases, we have neoangiogenesis, inflammation, and this ectopic endometrium can destroy and create chronic inflammation and fibrosis. So destroys actually the healthy tissue. Transvaginal laparoscopy, I proposed it as an investigation procedure for patients at high risk for ovarian cancer, all in 2004, and I invited a few colleagues to join me to this paper, but nobody wanted to join me. They say no, it looks to us very dangerous, very risky, we are not sure yet. So since 2004, I insisted on this technology, and you can see here is one of our first cancers that was diagnosed, and we published this in the European Journal of Gynecological Oncology. Later on, of course, our colleagues from Leuven, they supported a lot this idea, and we use this brush in also to get cells from the salpinx, because 2/3 of the ovarian cancer we know today that is developed from the tubes and not directly from the ovaries. And this is why probably if you use this brush, which is a brush that we use for bronchoscopy actually, is very thin one, you can introduce it into the fallopian tube, get cells from there. It takes only 8 minutes to do this job, and then you have a detection of ovarian cancer. So just to show you how it looks, the fibria, you can see in this way we penetrate actually with these small telescopes, and you can see the mucosa of the tube. And this is very well investigated for both cases of endometriosis or ovarian cancer, as you can see here. So we published, it was an invited paper by the Journal of Clinical Oncology and Therapeutics. This is a journal from MD Anderson actually in Texas, and we published our results from 67 asymptomatic patients that we performed the transvaginal hydrolaparoscopy to rule out ovarian cancer. These women were high-risk women because they had early age, that means below the age of 50, breast cancer. And as you know, these women, they carry the mutation gene of BRCA, the breast cancer antigen, and they are highly suspicious to develop also ovarian cancer. However, they wanted to preserve their fertility. They didn't have children, or they wanted more children. And the only way to be sure that in these cases they don't have ovarian cancer is to perform transvaginal hydrolaparoscopy. University College of London also invited us to show them how we do that. And indeed, we had a quite interesting collaboration. These cases were quite interesting, and most of these patients, they managed to get another child and then to perform prophylactic bilateral salpingo-oophorectomy because they were certain and they were sure performing the transvaginal hydrolaparoscopy. Now, this is the last part of my presentation. I'm going to talk a little bit about the embryoscopy. Is the direct visualization of embryos, and these embryos are after missed abortion, and unfortunately they have no heartbeat. But we perform the embryoscopy to investigate the reason, the cause of their death. And another interesting case of after IVF, this embryo with 21 trisomy, and among these 350 cases, this case was quite interesting because we transfer only one embryo, and we investigated the reason why this woman didn't get pregnant after embryo transfer and IVF. And you see in the hysteroembryoscopy that we can see one embryo only. But after a while, and after playing with the flow of the water, you see that finally it was a twin pregnancy. And not only twin pregnancy, but we have a craniopagus. That means the heads of both embryos were together, as you can see here. You see? Joining twins, actually. So it was a split of a single embryo. So we knew now, this is 4 millimeter embryo, 3 to 4 millimeter embryo. You could not see this in the ultrasound. You could see only one single area. And you see the whole embryos are going into my grasper, which is a 5 French grasper. You see how I engage them? And of course, I remove them to go for genetic analysis that they show a genetic malformation. This is another embryo, again, trisomy 21 with omphalocele and lip defects. And after this embryo, you see we cut the amniotic membrane because we wanted to remove the embryo and send it for genetic analysis. And we had the idea that probably this can be used for gene therapy of thalassemia. You know, today we have the ability to investigate and find out at the very early stage, or from the probably 6 weeks of gestation, if there is a thalassemia. And in that way, we can probably inject and perform gene therapy to these embryos. We are in discussions with our colleagues in the Institute of Neurology and Genetics, and probably will be able to perform it. In this video, you can see hysteroscopic management of cervical pregnancy. This is a very rare case because you can see there is no fusion yet of the heart. This embryo is found in the cervical part of the uterus, and you see that each part of the heart is beating separately because the heart is still not in fusion. So it's quite rare. We published this in this journal, and it was quite interesting. We received a lot of citations. And now, this is the last part, the guide, the gynecological artificial intelligence diagnosis. And it's a performance as a tool for a special doctor. We published also this just a day ago. And our idea is that we can use these technologies, the artificial intelligence, and to identify in a much better way the diagnosis, as well to identify the treatment in gynecological cases. These are 50 patients that underwent this procedure with artificial intelligence diagnostics, and the system show an accuracy up to 0.85, that means 85% more or less of accuracy. Due to lack of time, I think I will finish with this slide. So the gynecological artificial diagnosis can be probably in the future combined with the treatment, where the cases can be archived. The data processing, mining, can create algorithms and machine learning. The data fusion, of course, with images and laboratory and procedural cases can assist the surgeons to their procedures. And of course, the cases can be managed proposing several options of medication and surgery. And of course, remote surgery is another option as well. Gynecologists can train with these systems with real cases and simulations. Thank you very much for your attention. Looking forward to your questions.
Thank you, Vasilios, for a very interesting presentation. You've covered a range